Welcome to Best of the Day, ACG2016, for the second part of our series that we're presenting today with Russ Cohen. So Russ, welcome again. I'm Miguel Reguero, Professor of Medicine at the University of Pittsburgh Medical Center, and Dr. Cohen is a Professor of Medicine at the University of Chicago. So thanks again for taking the time. And tell me in this second part, what are some of the highlights? What are some of the best of the day that you saw at ACG this year?
Sure. Well, Miguel, today I think we'd like to talk about some of the data we saw in small molecules. So small molecules are molecules or medications that you can take orally because they're small enough to go across the cell membrane, so they don't have to be delivered by IV or by shot. And many of the advanced therapies for IBD for a number of years now have been those delivered only by IV or by shot of some sort. So now we actually have some possible therapies that are orally deliverable, which is very interesting to both the physicians and the patients as well.
Sure.
The first therapy is actually already on the market to treat rheumatoid arthritis. And this is tofacitinib. So tofacitinib is a JAK inhibitor, a JNK kinase inhibitor, and my understanding is that it inhibits multiple of the JNK kinases. There are some other selective ones that were not presented orally at this meeting. But this tofacitinib has been studied extensively in inflammatory bowel disease, particularly in ulcerative colitis. And there were two large phase 3 trials with tofacitinib was given at 10 milligrams twice a day, which is twice the dose that the rheumatoid arthritis patients get. So it's 10 milligrams twice a day or placebo. And they had positive outcomes leading to submission to the FDA for possible approval either later this year or next year, we'll see. But the two oral presentations that I wanted to tell you about looked at a couple of different issues that we weren't aware of. The first looked at how quickly does the medication work. So in the clinical trials, there's usually a primary endpoint, and the week 8 was the primary endpoint for the tofacitinib. So the question is, well, there's your week 8 data, which is very nice, but does it take 8 weeks to work? So how do you answer that? Well, what is done in ulcerative colitis trials, including this one, is that at week 0 and week 8, you have the Mayo score calculation. And the Mayo score has 4 components to it: the stool frequency, the bleeding, the physician assessment, and an endoscopic score. So the scopes were done at week 0 or at screening and then at week 8. But in between, you could get data from everything except for that endoscopic score. So the partial Mayo score can be calculated based upon the patient diaries and the physician assessments. And that's what these investigators did. And they looked at the partial Mayo scores at week 2 and week 4 as well as week 8 as well too. So their findings were quite interesting. As far as clinical response time, about half of the patients who had responded, or even more than half the patients who had responded at week 8 had already responded by week 2. So it was more than half. The remission was about half the patients who were in remission by the partial Mayo score at week 8 were by week 2. So that's encouraging, because what do you tell your patients? How long is it going to work? You don't know. But now you say, well, you know what? Maybe half to response, even more, 2/3, actually had some response just 2 weeks out.
So this is really interesting, very important, and I think as we talk about best of the day, these new small molecules, as you alluded to, are the wave of the future, have been here for rheumatoid arthritis. Now with tofacitinib, that 10 milligrams twice a day, so for the audience listening, higher than what we've used for rheumatoid arthritis. But like you said, our patients are sick, and waiting 8 weeks, while yes, it's nice in a clinical trial, we want to know earlier. So if I hear what you're saying, it's that 2-week standpoint or 2-week time point that you actually saw over 2/3 have a response, and nearly half the patients had remission, which is pretty remarkable that a small molecule oral pill taken twice a day can work that quickly. So I think this is going to be hot. I think we're headed towards a new realm of treatment. And how would you say, for the clinical practitioner who's looking down the line, what's your take-home message? I think I just gave you my thought, but how do you position, or maybe not position, but how do you think about this tofacitinib?
Well, so currently it's only available for rheumatoid arthritis at the 5 milligrams twice a day, or there's an 11 milligram once a day dosing. That's a formulation that's in the works or being released or has been released recently, just around now. The availability would really be based upon, for that lower dose, would be based upon applying to the patient's insurance company to cover it, in which case we would generally do this only after they failed other therapies that we've tried. However, in the clinical trials, if things go as we're hoping and this gets approval at the 10 milligram twice a day, then this would be an agent that one would consider using in patients with ulcerative colitis. The criteria, moderate to severe, does not mean severe. Just like all the biologics, moderate or severe.
Right. So it's not that sick inpatient who's failed everything and we're throwing everything at them. So you mentioned that there's another tofacitinib trial that the Best of the Day ACG2016. Tell me about that. What did they look like? What was that about?
Well, so the trials were the same idea. They looked at the experience from the two big Octave trials, 1 and 2, that have led to the submission to the FDA for tofacitinib, 10 milligrams twice a day. But what they looked at is one of the questions we always answer is whether prior anti-TNF use would be predictive of how successful this agent is.
Right.
It's a different mechanism than the anti-TNF agents, so going into this you could say, well, maybe it would work better in TNF failures because maybe that's not their mechanism. Or you could say maybe it worked worse because those TNF failures are tough patients. But of course, there's also the possibility that you can get a little bit of both, and which is probably what we did, or what they did, I should say. So in this analysis, looking at those two trials, there did not seem to be a difference whether the patients had prior TNF exposure or not, as far as the main outcomes in the clinical trials. But they did note that patients who had had a primary failure of an anti-TNF, meaning they never responded, they did not do as well as the patients who had had a secondary anti-TNF failure, meaning they had responded, then lost response, things too, and that's probably because the primary ones are tougher cases.
Right.
Maybe those are the patients who really need surgery. And the other thing is that if you looked at breakdowns of the Mayo score, so Mayo score is the worst is a 12, the lowest is a 0. Those who are 9 to 12, so those are really the severe cases, they didn't do as well either.
Right. So also interesting. I think when I hear you discuss and look at this, and as I think about our clinical practice with tofacitinib, I think the second trial that you're talking about said, you know what, doesn't matter if you'd been on an anti-TNF or not, although other trials before this have shown that prior anti-TNF use diminished the response. Tofacitinib didn't see that. And the other thing that was interesting is that moderate to severe patients responded well. So anti-TNF exposed, moderate to severe UC. And then as you mentioned, the sick of the sick and those that failed anti-TNF from the start, maybe that subset didn't work as well. So tofacitinib sounds like it works early, 2 weeks we see a response, and it works in patients who've been on anti-TNF in the past. So tell me, Russ, you mentioned there was another small molecule trial and maybe something we haven't been as familiar with. Tell me about that. What did that show?
So another interesting product that was discussed at today's meeting was ozanimod. So ozanimod is an SP1 inhibitor, a sphingosine 1 phosphate inhibitor, and it's a selective one for 1 and 5. There actually is a similar product already on the market for multiple sclerosis that is not as selective. So the benefit of this is to have the efficacy, but with a better safety profile. This agent already had good induction trial data where they looked at patients getting placebo or 0.5 milligrams or 1 milligram dosed orally daily. At our meeting, we had the long-term extension open label of the 1 milligram dose. So the purpose was to see if you could have efficacy and safety with long-term use of this medication. So again, this is an oral agent, very exciting, and the induction data was quite interesting to many people because it was quite good, also for an oral agent, as you mentioned.
Right.
And the maintenance, this open label extension, I should say, really actually did not disappoint. Again, it is open label, so everyone's getting drug. But not only did the people who were getting, and the 1 milligram was the only dose given, do quite well with a vast majority of the patients having minimal or no disease, when 90% in some of their outcomes doing well, but also the people who had gotten either the placebo or the 0.5 milligram, they improved to catch up to the 1 milligram dosers from the original induction trial, which was also very encouraging because you would expect to see that in a medication that works this way. So it's kind of helping this proof of concept idea where you're saying, you know, we really think this thing works, and look, the patients who are getting half the dose and the people who are getting placebo, they also get pulled right up, and we're doing by the end quite well as well as the 1 milligram doses too.
So I think, you know, this is exciting. Ozanimod, new mechanism of action, this S1P, finding that this open label extension at 1 milligram, as you said, safe, effective, and interestingly in those placebo and lower dose 0.5 milligrams actually pulled them up, and these remission rates were pretty incredible. So we're seeing a new era of these small molecules that will hit the market soon. And I think that this is something that we're going to hear a lot more about. My prediction, and maybe I'm curious to see what you think, is that tofacitinib and ozanimod will probably be what we see in the next few years, maybe. Obviously, it's up to the FDA and some of the regulatory guidance. How would you, when you're thinking about this, these are ulcerative colitis trials, correct? This isn't Crohn's disease. And I think for ulcerative colitis, what is the benefit to the patient for these? You mentioned some already, and just to put this in the context of small molecules versus what we're used to in the past. This wasn't done as a study, but maybe we can leave it at that and hear what your thoughts are.
Well, sure. I mean, it's kind of fascinating because, as you know, we only had oral medications for the longest time, and there were quite a number of pills with many of the agents for ulcerative colitis. So then when we finally had a medication, you only had to take as an infusion every 2 months or an injection every 2 weeks or every 4 weeks. The patients were ecstatic. Well, now they want to go back to the pills. So going back to the pills, it is a once a day dosing with the ozanimod, with the tofacitinib is twice a day dosing, but going back to pills, obviously you don't have the inconvenience and perhaps discomfort with the infusion or injection, and that may have some benefit where the patient feels they're more in control of their therapy. Some of the patients, as you know, are college students or travel a lot, so the oral may have the benefit as well too. The efficacy of the agents is quite impressive.
Looks good, right?
And the safety looks good too. And the long-term extension for the ozanimod, the other outcomes, the safety was quite good. It actually looks safer than the version that's on the market for the MS patients right now too.
So I think very exciting, and possibly the small molecules in terms of immunogenicity will be something that we're not going to talk about because these aren't monoclonal antibodies. So Russ, I wanted to thank you, and I think that in summary, tofacitinib, ozanimod are on the future, they're on the horizon. We saw good responses and interesting discussions at ACG this year. And I also want to thank the audience for Best of the Day 2016 ACG, joining me with Russ Cohen, having an interesting discussion in the second part. And that's going to close the second part, and stay tuned because we do have 2 more parts, part 3 and part 4, and I'll be joined by Susie Kane in those parts as well. So thank you for attending.